Hello. We are delighted to be a part of the Year in Review team, and I have with me Dr. Nita Nair, a senior consultant and associate professor in breast surgery unit of Tata Memorial Hospital. And I'm Sanjoy Chatterjee, a consultant clinical oncologist from Tata Memorial Hospital in Kolkata. So we are going to discuss in the next 3 or 4 minutes about the last year's seminal findings on loco-regional therapy, and I'd request my friend Dr. Nair to start off with what she feels about the breast conservation data presented in Lancet by the Danish team.
So thanks again, Sanjoy. So I think what we're going to look at is that we've had fabulous data covered over the last year. So the breast cancer group, or the breast cancer study that was published by the Danish group, was actually presented in 2016. There was a lot of ambiguity about whether or not we were able to accept that data with just the abstract, but I think a lot of that has been sorted out with the paper. Fabulous group, large study, large follow-up. All of it just comes down to an endpoint which suggests that breast conservation in early breast cancer is safe. Whether or not it is better than mastectomy or not is something we'll probably need to debate on that subgroup, but we're clear on the safety for early breast cancers. And I think that should be our take home from that abstract. I don't know if you have any other opinion on that.
I think that's absolutely fine. This year in review meeting is all about sieving out the gist from the major presentations in the yesteryears, and I think what Nita presented in the last few seconds is basically what we are all trying to do for each of the abstracts. Say, for example, the post-mastectomy radiotherapy recommendation by Astro and the post-mastectomy radiotherapy data from the BCIRG005. I mean, really, it is just a follow-on of the EBCTCG analysis, isn't it? And all it shows is that, again, in the 1 to 3 node positive group, there's really strong data now to support radiotherapy. Of course, there are certain ambiguities, like, would you like to treat the IMN in all patients, although it's an Astro recommendations that if you give PMRT, treat the IMN and lower supraclavicular lymph nodes, but really it is difficult to say that you should use it in all patients, isn't it?
So I think that's what, so talking about lymph nodes will always bring us back to our age-old problem of sentinel node biopsies and 1 to 3 nodes. We're always discussing 1 to 3 nodes, whether it's PMRT, whether it's sentinel node biopsies, and how we're taking that forward. The data, of course, as Sanjoy says, for PMRT seems to be robust enough. But if you look at sentinel node biopsy and Armando Guiliani's group, which talked about the ACUZOG Z11 or the AMROS data that came after that, and says 1 to 3 nodes, do nothing else, I'm not sure our population necessarily fits into that entire subset.
Isn't that exactly what we are trying to do with YIR, isn't it?
Absolutely. So which is what we're looking at in that data, which says if you find a patient that fits into the population, which is that study's criteria, the data is robust enough to answer that question, not necessarily as a general statement. So if you look at the ACUZOG updated analysis, which I think is a 10-year or 11-year analysis that they've published. So it's a 10-year analysis which they've published. And we're talking about a small group of patients, which is early breast cancer, small tumors, low grade, ERPR positive. Can you then, in a micrometastatic or low volume disease in the axilla, consider a 1 to 3 sentinel node biopsy and observe the rest of the axilla? Probably yes. But I think if you're talking about populations that we see either at your center or at ours, which is across the country, it's a slightly different population.
I think that's exactly what Year in Review is trying to do. In that, yes, it is this evidence, yes, it's presented internationally, but what Dr. Nair is trying to say is, in her population, in her practice, and in our practice in India, how much can we actually accept that? And could you just explain that a bit more with this?
So if we were to look at what we see as a standard across our population, metastatic lymph nodes, we don't see small micrometastatic lesions. We also see higher grade 3 tumors, and a very small proportion is probably grade 2 or grade 3. None of this was what was the acceptable group in that study population.
You're so correct, isn't it? I mean, like if you compare it to the ABCSG data and the Z11 data, there's double percentages of grade 3, significantly increased number of node positives. So really, are we going to accept the data blindly? No. But like Dr. Nair rightly points out, if you've got that criteria, certainly use it. But again, understand the data and then use it in patients in general cautiously. Isn't that correct?
So we need to extrapolate correctly. specifically rather than generally. I think we find the right patients and then we're able to use this data quite accurately. So I think that's what I'd ask you. We debate about margins, we talk about DCIS, we fight between surgeons and radiation oncologists all the time. It's easy for me to turn around and say that I've adequately excised it, but I think the data looking at margins now talks about something else.
It does, doesn't it? I mean, if you just look at DCIS, I mean, now at least as surgeons and as clinical oncologists, radiation oncologists, we've got a number to work with, say 2 millimeters for DCIS, no tumor on the ink margin for invasive cancers.
Yes.
And that's again an important thing that we can do to try and move forward, isn't it?
So I think that's what I liked about the year-end review, and what we get to do is you don't just read the data, but you get to look at how you can clinically apply this back at home and in your patient population, and then you're able to use the data more accurately,
Absolutely.
I think.
Thank you.
Thank
and we look forward to the next year in review conference.